Now, to kickstart today's conference, we will start off with our first symposium for the day on community-acquired pneumonia. To moderate this symposium and invite the guest speakers, I would like to call upon Dr. Niranjan Disanayake, President of the Sri Lanka College of Pulmonologists and Consultant Pulmonologist at the Teaching Hospital, Kalutara. Sir, over to you.
So as I promised, this will be a roundtable discussion. Right, so we'll start off with the first symposium on community-acquired pneumonia. It is indeed a pleasure to invite Dr. Geeta Pereira, my good friend and a past president of the college, as well as the consultant pulmonologist at Sri Jawadharma Hospital, to the podium, and Dr. Vaidehi Rajivan, consultant microbiologist and senior lecturer at the Eastern University, Atypical. Our joint secretary, a very dynamic character, Dr. Upul Patirana, to talk about the unusual presentations and when to suspect certain organisms. And then we have Dr. Nalika Karunaratna, who will be discussing about the severity assessment in community-acquired pneumonia. Right, so without much ado, I think I will hand over the microphone to Geetal, who will be presenting from here.
Good morning. I'm glad I'm doing the first presentation because not many are here. And also it's going to be the lightest of this discussion because as we go along, it's going to get deeper and deeper and more scientific and more scientific. So I'm supposed to be talking to you about differentiating community-acquired pneumonias of different types. Now, when you look at the ICD, pneumonia is defined like this. But nobody really looks at ICD for pneumonia, unlike in psychiatric diseases. So the important points are that it's infection of the lungs. You don't have pneumonias like in the gut or anything like that. And it has to have fever, chills, or any respiratory symptoms. So when our surgical colleagues say that this patient is having pneumonia and take over, you got to see that they have the respiratory symptoms at least, apart from the gangrenous legs. All right? And if you want to diagnose pneumonia, you have to have some X-ray evidence of lung infiltrations. And then when you go to the subtypes, you have the bacterial pneumonias, viral pneumonias, fungal pneumonias with codes. And but we are not going to discuss any of these things in this order because as clinicians, we have different concerns of treating our patients, and we need to have different criteria to do that. Right. So you have the classification by the site of acquisition. So community-acquired pneumonia is the commonest. You have the other ones as given here. And we will be discussing all these other things will be discussed in due course. So community-acquired pneumonia is acute infection of the pulmonary parenchyma acquired outside of healthcare settings. And then the classification by etiology, this is also will be discussed at least partially. So you have the typical bacterial pneumonias that we all think of when we think about pneumonia. You have the atypical pneumonias, what we call atypical pneumonias, we'll go through that, and then so on and so forth. Viral pneumonias and fungal pneumonias are also there. So a little bit of on the pathogenesis because it's kind of interesting, I thought. Earlier, we thought that pneumonia is something that you get from droplets or whatever that gets into your respiratory system, and the respiratory system is nice and sterile, and these things go in, and depending on their virulence, they cause infections of the respiratory tract, especially in the alveolar level, and that's how pneumonia happens. And then you have then we started talking about the microbiome model, where you accept that there are microorganisms living inside the alveoli as well. And when something else comes from outside, it has to fight with the microbiome. The microbiome does things to your immune system to say that don't let these fellows come. And then if that, depending on how it works out, you get a pneumonia or you get away with it. Or If you are weak, your microbiome also starts playing up and cause a pneumonia out there, right? So these two models will help us understand the type of pneumonia that we get, because it depends on all these interactions. Just a graphic, I won't go into that. So now coming to the topic, how do you differentiate between pneumonias? Now at times it's difficult to differentiate between bronchitis and a pneumonia, right? All of us go through this during our clinical practice. So you use this the same tools that we have. You have the clinical features. So these are not 100% specific to pneumonias. Any respiratory infection could have all these things. And so you have to spend some time asking them what they have, right? And of course, you remember that in elderly people, sometimes pneumonias may not, or immunosuppressed patients may not have the typical features of respiratory symptoms. And then you get a patient in front of you. Your chances of diagnosing a pneumonia in a patient with lower respiratory tract infection goes up when the patient is older. Or if they have chronic comorbidities like renal failure or CLCD or immunosuppressed. And then if they have had a viral infection recently, the chances of them going into that. And if they have impaired airway protection, like if they're having Parkinson's or if they're aspirating after a stroke, then the other lifestyle issues like smoking and overcrowded places. And of course, the physical examination, all of this in books you have about dullness and the physical features of pneumonia. You may or may not see them depending on how well you hear and how well you listen. But you can't depend on them all the time. Then you have the investigations. Of course, imaging is important. As I said, to diagnose a pneumonia, you have to have some infiltrates in the lungs. And of course, chest X-ray is the standard that you talk about. Of course, CT can show things that you can't see in the chest X-ray. And lung ultrasound is coming in a big way because it can be used at point of care. Sometimes you don't have X-rays at point of care, whereas ultrasound may be available if you have the machine. And then this is important, the nucleic acid amplification techniques. Now, all over the world, to get a microbiological or organ-wise this thing, you use these techniques to identify the infections. We don't. We use serology and then other non-respiratory samples like CSF when you have other sites involved, and then of course the cultures, which take 3 days at least, or somebody might say it's 24 hours. And then you diagnose the pneumonia once it fits into the diagnostic criteria. Demonstration of an infiltrate and with a patient with this thing. Typical community acquired pneumonia, basically what we mean in general life is pneumonia due to pathogenic bacteria like streptococci, staphylococci, Haemophilus and things like that. So you expect them to infiltrate like this and probably cause a little bit of effusion or parapneumonic effusion and could end up having a empyema. So so you see a picture like this on your X-ray, you know that you are probably dealing with a typical, so-called typical pneumonia. Why it's important is because it will have implication on the antibiotics you choose. We will go into that as we go. But when you see a community-acquired pneumonia like this, be a little careful because you have some special types of pneumonias in this typical group, like this community-acquired MRSAs. When you have staph going in the coming in the picture, you will have a different ball game to play with cavities and all that. And then if you have conditions like this, MRSA skin infections in the patient in the before, crowded living conditions, MSMs and things like that, be a little, and if the patient is very sick, think about that. And then you have the classic Klebsiella pneumonia with the bulging fissures. You see this in clinical practice, not only in books. You know that you may be dealing with a Klebsiella. Sometimes Klebsiellas can be nasty, so you got to choose your antibiotics wisely depending on the situation. And then the Pseudomonas. Now, Pseudomonas, you know, different ball game is another ball game, because in these debilitated patients, sometimes the normal antibiotics that you choose don't work. So you got to think about Pseudomonas when they have structural lung diseases like bronchiectasis. We get a lot of them. So look at them. Then coming to atypical pneumonias, are these atypical organisms that generally don't have cell membranes, like chlamydia, mycoplasma, and things like that. The important thing is that they are supposed to be, most of them are mild, and they have indolent onset. Some of them get better on their own. But what we see are actually the bad atypical pneumonia. So what we see could be nasty, but then most of these things people get, and they get over them also. The X-ray findings I'll rush through. X-ray findings could be more subtle than the typical pneumonias with a lot of interstitial kind of shadows, and then I'll skip that also. The white counts can be normal, and as all of you know, there can be a little bit of liver enzyme elevation, hemolysis, and that kind of thing. You are looking at atypical pneumonias. And then there can be extrapulmonary features like myocarditis and endocarditis also. Viral pneumonias, once again, we see a lot, because after the COVID pandemic and influenza coming in these days, we see these hazy shadows. And also you got to remember the mycobacteria, our friend, atypical and typicals, they are not very acute. Fungal pneumonias are also there, and the PCP pneumonia in immunosuppressed patients especially, but you see that in immunocompetent patients as well. Now, what I want to say is that basically diagnosing pneumonia is common. We diagnose only part of them, and you need to use your clinical judgment as well as this all this technology, and a little bit of common sense also when you treat the patients, because you can't stick to that. Thanks. Sorry about
Yeah, thanks, Geetal. I think basically the overview of whether it is typical, atypical, or whether it is viral basically depends on the clinical picture that the patient has, the radiological findings, and the serological markers. And because microbiological confirmation might take a little bit of time, sometimes still we rely on these three parameters to come into a conclusion of whether this patient is having what is the underlying cause of these pneumonias, and hence our treatment options will differ depending on that. So hence it's very important to identify these clinical features and to suspect these underlying etiologies correctly at the initial presentation of patients. Thank you very much, Geetal. And now when we come into these patients with pneumonia and we have queries, and our microbiologist comes into the rescue, and I think it's time Dr. Vedehi that she will commence his presentation on diagnostics and treatment.
Thank you for the opportunity. Good morning to you all. Before starting, I kindly request you all to take your mobile phones out, and because we have an online poll, a quick poll. So take your smartphones out and type menti.com on your phones, and you can enter the code that appear. When I change the slide. So once you all read this, I will change it. And don't worry, your identity cannot be traced at any point. So the code is displayed on the top that you can see. It's difficult to read from here. 230885, I think. Hope you can see. 23008185. Yeah, okay. So when you type in, you can log into that, and you can recall your third year, fourth year medical students period. That what etiological agents do you consider when you dealing with patients with CAP? only your menti.com, and then you type in the code, then you can join in the poll, and your answers only will be displayed.
We'll go ahead.
Okay. Yeah, good. Yes. Very good. Very good. Considering the time, yeah, very, very good. So now with your thoughts, compare with that current evidence. So it's a systematic review of articles published in English language from January 1945 to March 2020. I didn't do that. It's a published systematic review published by an American team of researchers, and they found out that CAP in adults from developed countries, 146 papers and 82,000 odd patients. So look at the causative agent. So then you see still your thought is also correct. Common is 33 to 50% Streptococcus pneumoniae, and then even after Hib vaccination, still Haemophilus influenzae is still circulating around 7 to 16, and then Mycoplasma, Staph aureus, Enterobacteriaceae, and then Legionella, Chlamydophila, Pseudomonas, and goes on. And see the viral part, influenza still common, and then rhinovirus, the second common cause according to their study, and RSV, human metapneumovirus. So then my point here is bacterial and viral co-infection in around 40% of cases. So that we cannot forget, around 40% of cases. And then they specifically mention the Streptococcus pneumococcus isolation rate. It started to decline at the latter part of the analysis. So what does it mean that we need to think of? So I just want to put that as quoted by that study. So that on average, no matter which category of microbiological testing was done, no etiologic agent for CAP could be identified in more than one half of cases, 50 to 67.1%. You don't have a diagnosis even at a higher centers. So even with the addition of more sophisticated techniques in the past 2 decades, including routine utilization of PCR, identify atypical bacteria and viruses, there are no tendency towards an increased identification of a pathogen. 2 recent studies, however, so that they did the quality of sputum, they focused on the quality of sputum, then they have got that 87 to 95%. That gives some hope, but a single center study. Right. So it's so then that's a Western data. Eastern data, Chinese data, multi-center study in China, but it's a prospective study from 2014 to 2019, pre-COVID. So they did 3,403 hospitalized patients and so adult patients. So then let's see that they are finding they have Mycoplasma pneumonia at the top. So then again H. influenzae. That their reason is Hib is not widely given in China, it seems, Hib vaccine. So that may be the reason. And the research team recommended the implementation of it. And then Klebsiella, see the percentage, 10.43 Klebsiella they are found out. And then influenza, human rhinovirus. And pneumococcus, see where the pneumo is placed there, it's in not even in the middle, fairly towards the lower down. And then staph and adeno. So then their focus is these are the organisms were found in 80% of all positive cases. Still again, they also were able to identify only 60% of cases with a pathogen. So still the gap is there. So single pathogen in around 40% and multiple pathogen in around 20%. So then another interesting finding that I found, this is a systematic review by a Vietnam team, 1990 to 2012, and then the rounded ones are, not the round is gone down a little bit. Staph aureus and gram-negative, see the percentage, compare with the Western and the East. So Asian countries, Staph aureus 4%, while European studies 1.4. Asian countries, gram-negatives, enteric pathogens 9.0, where the European 2.7. So that we are dealing with something a bit different that we need to consider. So diagnostic yield of clinical specimen, just when you think of it's a good quality specimen, if it is a good quality specimen that is less than 10 epithelial cells and more than 25 pus cells, and then your detection rate goes up by 87% by PCR. and still 39% by culture. So that is our real. But this is again a single center study, but a very quality study. And when you consider blood, that's the that we think main thing, because our sputum quality is very much lower. Still, the detection rate in blood is 2 to 9%, then we will be missing quite a lot of patients when we rely only on blood. So that is for your thoughts. And what antibiotics can we start empirically on patients with CAP? So then ATS IDC guidelines 2019, that's the latest one, and that's they say with outpatients with no comorbidities, then you can still manage with amoxicillin, doxy, clarithrol. And with comorbidities, then you may need to have coamoxiclav and plus clarithromycin or a respiratory quinolone alone. Then we need to keep in mind with the TB prevalence. And inpatient, non-severe, then you have a choice of third generation cephalosporin plus macrolide or a respiratory quinolone alone. If it is severe, then you need to go for third generation cephalosporin plus macrolide or respiratory quinolone, no single monotherapy. And if it is MRSA and Pseudomonas, then we need to cover that as well. That's the Empiric antibiotic guideline, as very briefly. And these are my references, and we can keep our questions at the, for the last or whatever.
I think we can keep the questions at the last, and I think there are some very interesting highlighting points in your presentation, Dr. Vedehe. We will further discuss during the panel discussion. As you said, correctly said, the typical pathogens that we have found previously, like streptococcus, is gradually, probably it is reducing in intensity. When you find it, it is reduced, probably because of the pneumococcal vaccination might be one thing, and the other thing is that, especially I have actually read a beautiful study, paper done by the Jaffna Teaching Hospital, where they are identifying more gram-negative organisms coming to acquired pneumonia, as you correctly highlighted. And probably the reason that we are identifying more patients with pneumonia with atypical organisms like mycoplasma and some viral infection is because of the increased diagnostic abilities that we are providing and the abilities and the facilities that we have in diagnostics. Actually, we did a small study in pregnant ladies in Ratnapura as well. So there also we had influenza A was the most prominent organism, but followed by COVID, and then we had a few mycoplasma cases, Legionella, and we had actually Bertella pertussis one case as well. So there are different types of organisms, and hopefully we might be able to discuss during the session with the participation of the with the audience.
One more emphasis on the Jaffna study. Sorry that my slides got missed that part. So there's a recent study, but single center, but teaching hospital covering the northern region, 283 samples, and they found the 40% of the pathogen were gram-negative, this is Klebsiella. So that tells us some important message too, that we need to have a national study to collect national data on that. Thank you.
National data and thinking about the regional variability as well, isn't it? Depending on the where our countries, where the regional and the geography might be also coming into the picture. Okay, so. Because you finished early, we were able to discuss a little bit about these things, and I think it is now Upul's turn to help us identify these unusual presentations of the community-acquired pneumonias. Over to you, Upul.
Thank you very much. Thank you for asking me to talk on this unusual topic of unusual pneumonias. So our previous speakers discussed about the microbiology of community-acquired pneumonia, and also our clinician Dr. Geeta Alpera pointed out. So we have formal definitions for these typical pneumonias, atypicals, and next we are going to discuss about HAP, all have formal definitions. But for unusual pneumonias, there is no such formal definition. And also Dr. Geeta Alpera pointed out that we need to have this nucleic acid amplification testing, cultures, rapid cultures, and also the serologies to make a microbiological diagnosis. Unfortunately, most of these tests are not available for us other than the common organisms, and also even though it is available in private sector, they are very expensive, not affordable for our patients. So therefore what I am going to do is, as clinicians, with available tools, how we can suspect these unusual pathogens. Right, so we made the diagnosis of community-acquired pneumonia based on the clinical presentation, and this is in coupled with radiography. And the plain chest radiograph is the initial testing, and you see 3 common patterns of community acquired pneumonia. The commonest is lobar pneumonia, the lobar pattern, and also there are multilobar pneumonias, and also there are diffuse interstitial opacities. So the diagnosis is straightforward in typical presentation in couple with the radiology, and we will start the treatment with empirical antibiotic therapy, sometimes antivirals as well. So what we expect is the recovery of the patient. So once we start treatment, following day we expect some recovery. So what we expect is, so within 3 to 5 days, subjective improvement of symptoms and generally feeling well. And also it will take some time, 2-3 days, to improve cardiovascular parameters, and also more than that for respiratory parameters. And also symptoms might persist even beyond weeks. And when we come to the infiltration on chest radiograph, so most of the studies done on this natural history of community acquired pneumonia describe the resolution of radiography, and it is defined when the radiographic abnormalities persist beyond 4 weeks, it is slow resolution. So what we have to think in these patients, the delayed resolutions, all of the patients won't improve as I described in the previous slide. So we should think about the age parameters, severity of pneumonia, infectious agent, and also the associated comorbidities, rather than jumping and saying this is non-resolving pneumonia. And so these unusual pneumonias, the presentation might be unusual. Like for example, elderly patients, the presentation might be the change in mental status, confusion. Or sometimes the patient presents with a surgical casualty with acute abdomen, might be due to diaphragmatic pleurisy. And also there are patients with very subtle clinical signs. And also when look at the chest radiograph, hardly any radiological signs, but still it is pneumonia. And so we discussed so far that the commonest organism, Streptococcus pneumonia. But what happens is, because of the vaccination, the incidence might be going down. And also, we commonly manipulate the immune system to treat the inflammatory disorders. And also, we have now number of organ transplant recipients, therefore we suppress the immunity. The unusual organisms are coming up. And also, these patients, we should think about non-resolving pneumonias with complications of pneumonia and problem with host defenses, and also misdiagnosis of pathogen. So, and also at the same time, when you deal with the patient with difficult pneumonia, we should think about non-infectious etiologies as well. So in my talk, mainly concentrate on this misdiagnosis of pathogens. So I'm thinking about the organisms other than the usual pathogens. So as we know, the community acquired pneumonia caused by community acquired MRSA is well known, and how we as clinicians suspect. So these patients have a very rapid course, and they develop necrotizing pneumonias, lung abscess, empyema, and rapidly fall into respiratory failure and also septic shock. And these patients, probably they have past history of community acquired MRSA infection, or they are colonizers with community acquired MRSA. And also the Pseudomonas infection, because we don't cover with our empirical antibiotic for Pseudomonas infection usually. And these patients most of the time previous colonizers, and also patients with underlying structural lung disease like bronchiectasis. And the other organisms, so I worked previously in Ampara and also Trincomalee. So these endemic areas, we see quite number of patients with melioidosis. And they also, we start treatment, they don't respond to initial antibiotic treatment. And in few days time, we receive the culture report with melioidosis. And exactly the problem with melioidosis is the acute presentation, it is similar to community acquired pneumonia. And when it is subacute or chronic in presentation, it mimics tuberculosis. So this patient actually, a patient with melioidosis had similar radiographic findings and similar presentation to community acquired pneumonia. And he also complained abdominal pain. Therefore, we proceeded with CT abdomen, showed hepatosplenic abscesses, and later culture positive for Burke-Calderia pseudomallei. So confirm the diagnosis. And again, even though this is very uncommon disease, sometimes the flora in the oral cavity also can cause this anaerobic infection with upper airway infection and affecting the internal jugular vein with thrombophlebitis, and also multiple metastatic lung abscesses. And this is these are friend, as Dr. Geetal said, the Mycobacterium tuberculosis. So when it present like global pneumonia, when it is a cavity or miliary opacities and sputum smear is positive, diagnosis straightforward, and it's not a difficult one. But it is like consolidation and also smear is negative, so we are in trouble. And actually, so how we as clinicians suspect is there are radiological patterns in tuberculosis. The commonest site, the apico-posterior segment of the upper lobe, even though it is just described upper lobe dominant disease, apico-posterior segment, and the apical segment of the lower lobe. So these patients are having tuberculosis more likely, and milioidosis also affect the same segments. And we have now, so all over the country, the more sensitive test, Gene Expert. So remember, MAN2 is not a test to diagnose active tuberculosis. And again, this patient also came with respiratory symptoms and fever, not responding to antibiotic. You see, this is not the common lobar pattern or multi-lobar pattern. And therefore, we have another tool. We proceeded with the HRCT chest, so which is useful in detecting nodules and also more subtle consolidations, ground glass opacities. And you see here more nodules, screen blood opacities. Therefore, we proceeded with bronchoalveolar lavage. Again, another tool for us, and which showed Gene Expert positive in bronchoalveolar lavage, making the diagnosis of tuberculosis. So when we talk about HRCT chest, it is more accurate than the plain chest radiograph when detecting some pathological abnormalities. But you have to remember that this is not routine, and this is adjunct to the other investigations. And the bronchoscopy, another tool. We can take samples from bronchial wash or bronchoalveolar lavage, and it is more sensitive than, these samples are more sensitive than just taking sputum for smear or Gene Expert. And this is another pathogen. This patient also I saw in Ampara, and came with community acquired pneumonia, and patient was in respiratory failure. Initially responded to broad spectrum antibiotic, but persistent fever and also radiological opacities. Therefore, we did CT. You can see the opacity in the right lower lobe, and also there is bronchial obstruction. Therefore, we did bronchoscopy. You see here the characteristic appearance of mucormycosis. The pathologist confirmed the diagnosis of mucormycosis. The similar appearance might be there with invasive aspergillosis as well. And also this patient, again, this lady came with respiratory symptoms, and also patient was in respiratory failure, and hardly there were any lung signs. And you see some ground glass opacities in the chest X-ray. So we proceeded with the HRCT chest. And you see the oral cavity before going to the CT. And this is the HRCT chest. You can see ground glass opacities and also the cystic lesions. Confirm the diagnosis of HIV infection. This patient, we started treatment for pneumocystis pneumonia, which improved its treatment. And this patient also, again, another cancer patient, was on cancer chemotherapy. And he came with respiratory failure and fever, and initially we suspected pulmonary embolism, which was confirmed, but after starting treatment he deteriorated, and you see the radiological worsening also, and you see here HRCT also more ground glass opacities, and we suspected CMV pneumonitis because cancer chemotherapy patient, it confirmed the diagnosis by doing blood and lower respiratory sample PCR. And this patient, again, another patient, this patient actually came to us with typical features of pneumonia. She became unconscious and needed intubation and ventilation and not responded to broad spectrum antibiotics. And we noted patient had some herpes labialis and herpes stomatitis. Therefore, we suspected herpes pneumonia. So we went ahead with bronchoscopy. You see here hemorrhagic tracheobronchitis and also whitish plaque. We took biopsies from the lesions also, which demonstrated some cytopathic lesions, and the blood and the lower respiratory sample PCR came as HSC pneumonitis. So we started treatment with acyclovir with complete recovery of the patient. So therefore, we have to think about in these patients with the unusual presentations and the delayed response and non-resolving pneumonias and uninfectious etiologies. And these are the organisms usually we think about. Other than the usual pathogens, the bacterial organisms like community-acquired MRSA, Burke-Cold-area pseudomallei, and also TB and NTM, fungal infections, pneumocystis jirovecii, and uncommon viruses like CMV, HSV, and also rare uncommon organisms like actinomycosis and nocardia. I know there is an exhaustive list of organisms causing pneumonia, but for the time being, these are the things initially we should think about. Thank you very much.
Thank you very much, Shupul, and for that extensive cover of the unusual people or unusual organisms that usually we don't think about, and we know when to think about and what to do when we have these patients in front of us. So there is one good thing, I think. So basically, these patients we diagnose the clinically with our clinical sense and with the help of our microbiological colleagues. So at least in clinical medicine, I think artificial intelligence will not replace the doctors for another 10 years, hopefully. So we are coming into the fourth interesting topic, where we are now dealing with the pneumonias, patients who are presenting to the hospital, and then the patient is deteriorating. We will call our critical care colleagues to help us, and he will discuss about the severity indices and how to measure the severity of pneumonia and what are the things that we should do in these patients. So Dr. Nalika Karunaratne, it is up to you now. Thank you.
Thank you, Thank you, Niranjan, and good morning, ladies and gentlemen. It's going to be a straightforward topic, nothing much to think about it. So we will talk about severity assessment in community-acquired pneumonia. So why it's important as a primary care physician or a secondary care physician, by using these scores, you can decide where we should treat these patients, whether you should hospitalize these patients, requirement for intravenous therapy or not. If you admit this patient, what level of monitoring or what level of care we should give to this patient. So that's the idea of this. So if it's a good scoring system or a tool, it should be accurate, and it should we should be able to use it in different healthcare settings, and should be simple. So this is a receiver operating characteristic curve. If your tool is a good one, the area under the curve should go more than 0.7. That means that's a moderate discriminatory value. More than 0.8 is a good, and more than 0.9 to 1 is excellent. So we'll see a few of these scores and where these scores lies. So shall we talk about the PSI and curve 65? The PSI, or the port score, sometimes it's called port score. Why? Because the port means the patient's outcome research team, one of the cohorts of the original study, a prediction rule to identify low-risk patients with community-acquired pneumonia, which was published in 1997 in New England Journal of Medicine by Fine et al. Just to show you how many patients involved in these two cohorts, the port validation study and Medil's group study, more than 50,000 patients were used. And they have measured the 30-day mortality. And the area under the curve is 0.74 to 0.83. Mainly it's a good value. Once you apply your score, you will get 5 classes. 1 to 3 is low risk, and 4 to 5 is high risk for 30-day mortality. So how do you calculate this? This has about 20 variables of demographic, comorbid, and clinical data. So it's a bit difficult to calculate if you do it manually. It's a 2-step calculation. If you get at least 1 yes, then you have to go for the step 2. I'm not going to discuss about each and every parameters there. If it's no for all the parameters there, then it's a class 1. At least 1 positive, then go to the second stage. Then you can calculate the class 2 to 4. But the easiest way is to use your the device and use an online app, which will give you the results, the mortality, and even the recommendations. So that's easy. So what are the recommendations in this PSI study? When it comes to class 1, 2, and 3, it's low risk. When it comes to class 1 and 2, basically they suggest you can treat in outpatients. But when it class 2, maybe outpatient or observation admission. Class 3 and 4, it's inpatient admission. That's the recommendation. So the curve 65 or the CRB 65, which is more familiar to us, I think. Again, it's a very robust tool and presented in 2003 in the Thorax Journal, defining community-acquired pneumonia severity on presentation to hospital and international derivation and validation study by Lim et al. So its area under the curve value is almost similar to the PSI. So it's another good study, good score to use. We all know these parameters: confusion, blood urea level, respiratory rate, and blood pressures and age. All get one score each, and then you can get the score. It's again in par with the PSI score and almost same suggestions. First 0, 1, and 2, maybe the outpatients. When it comes to 3, you have to decide whether you need hospitalization or not. 3, 4, 5, it should be hospital admission. And considering intensive care, but I will discuss it later. When it comes to this score, it's use blood urea level. So sometimes in the primary care level, even in the hospital, if you don't have blood urea level, still you can use this by CRB65 because it's been validated and it's almost equal to the curve 65. So without blood urea level, you can use this and almost the same risk categories and the recommendations. So that's very easy to do. So strengths and weaknesses of these 3 studies, all these 3 scores are very well validated and therefore we can use. The weaknesses, mainly the PSI has number of parameters, but the main weakness is these 3 scores doesn't give you a proper idea about whether this patient need intensive care treatment, intensive respiratory therapy, vasopressor therapy or not, because it's area under the curve value less than 0.7. Having said that, even though the scores can suggest you what to do, it always involves all the other things around you, whether this patient you can say that you can go home and take the treatment, but if this patient is profusely vomiting and if he can't take the oral medication, then you have to take the decision depending on that. Then the empyema, lung abscess, and metastasis, these complications are not addressed in most of these scoring systems. So these things come into the picture. Then the high-risk pathogens, as other colleagues discussed, and even the local policies and criteria. So the score can suggest you, but you have to decide what's best for the patient. When it comes to the intensive care admission, this is one of the very good tools. IDSA means Infectious Disease Society of America, and ATS, the American Thoracic Society consensus criteria. It has, if you have one major criteria or 3 or more minor criteria, then you should admit this patient to the ICU. But this is not a predictive score. If you see the major criteria, it says invasive mechanical ventilation, and number 2 is a specific septic shock with need for vasopressors. It's straightforward. If it's there, you have to send to the patient to the ICU. It's not predictive. So therefore, this one is doing very well. Its area under the curve is 0.9 and above. So, but it doesn't help much. So when it comes to smart COP, it's one of the another good score presented in 2008, a study done in Australia by Charles et al., a tool for predicting the need for intensive respiratory or vasopressor support in community-acquired pneumonia. This one is then validated again by using existing databases, 5 databases, including the port. So it should be a good study. And the area under the curve is 0.72 to 0.87. So you can use this for the ICU admission. Calculation, the name itself comes from the first letters of these variables. It's a bit of cumbersome to calculate because the age-related changes are there. Again, it's now the smart era, so smart COP can be calculated by using the smartphone, so it's easy. What are the recommendations? The 0 to 2 is low risk group, minimal risk of invasive respiratory therapy or vasopressor therapy. That means ICU admission. 3 to 4, the moderate. 1 in 8 might go to the ICU. 5 to 6 is a high, consider the ICU admission. 1 in 3, more than 7 is 2 in 3. So those are the recommendation in Smart COP, but as I said, there are some other things like sepsis scores, like Q-SOFA, SOFA, PUCH2, new score. All these things are important. Of course, the local policies. And as he mentioned about the AI, the way forward, now a lot of AI-generated scoring systems are coming on, and it seems they are very good and they are high up in the rank. And I saw the ATS has published even in 2019 and saying they are outperforming the new scoring system. So that's forward going on. So we will reach there. Thank you very much for listening.
Thank you, Nalika, for that brilliant overview about the severity in disease, as well as and you highlight the practical importance as well. Rather than looking at a single digit or a score, as clinicians we have to look at the patients as well as the surroundings and the facilities that we have when we make decisions. So, for example, if every patient with vasopressors with pneumonia, if we have to send into the ICU in Sri Lanka, I think in Teaching Hospital Kaltura we have only 5 ICU beds, right? And so we can understand the problems that the intensivists, the anesthetists will undergo if we try to implement this as it is. But we have to think about the local policies, the patients, and other factors coming into the picture as well. So we had 4 brilliant discussions about community-acquired pneumonia. I know that you might be burning with questions, so I will give a little bit of chance to get your thoughts together. So I will put Geetal, my good friend, into difficulty first. So basically, now Geetal, when you are consulting a patient in the hospital, tell me 3 things that you might think that this is a typical pneumonia. You have only your clinical acumen and the examination findings only, right? So no radiology. So is it a typical one? Whether you will start treatment with the broad spectrum, the rational antibiotic policy, or is it be viral, right? Or is it an atypical organisms? So what are the 3 things that goes through your mind?
Yeah, good question. What happens is in clinical practice, I'll try to be as practical as possible. How I would look at it is, what will happen to this patient if I don't treat him? In the next 6 hours, 24 hours, what will happen to him? If he's going to die, then you hit him with everything that you have, right? Now, we not only at the even at consultation, you get patients who are low in their oxygen saturation. Now, if I don't manage this within the next 24 hours, we have to put him in the ICU. So, then whether it's viral, bacterial, typical, atypical, TB, doesn't matter. You have to keep them out of the ICU. So, you got to use it. And then the other important thing is, now, if the patient is with me, then the close monitoring. That is very, very important. You don't go and decide on somebody's antibiotic now and then don't look at him for 3 days and come back and say, probably this is atypical, we should have started on something else. Of course, I would use whatever I can depending on the situation of whatever that we discussed about, whether there is a lobar consolidation or whether there is a effusion or whether there is no effusion or whether this patient is pale or that kind of technical stuff. But when it comes to real life, you're sitting in front of the patient and then you don't say that you're not icteric, so you're unlikely to have a atypical pneumonia. You have a effusion and then you're not going to. This can't be a viral thing. It can be a secondary infection of a viral infection. So all possibilities are there. I'm talking very practically, not at all technically, because you got to save the patient.
Thank you, Geeta. Any questions from the audience? Yes, Advan, yes.
My question is also from Dr. Geetal. So in clinical practice, how important it is to differentiate the typical and atypical microbiological organism? Because in our empirical antibiotic treatment is intended to cover. So that my belief is that we shouldn't try to differentiate clinically whether it is due to the typical bacterial pathogen or atypical bacterial pathogens. Anyway, we are going to provide an empirical cover for both pathogens, isn't it? So our empirical...
Not really, Adhavan. I mean, in my practice, when we have time, you can wait for the full blood count to come. You can see how your initial antibiotics work. Say for example, somebody with bronchiectasis comes, and then you have a situation there, and then you have no evidence that that he has got something from somewhere else. And then you have time to till the investigations come. I don't have to put them on clarithromycin whether they have gastritis or not.
I agree.
So,
that it's patient with a structural lung disease is a separate entity.
Say in the,
I agree
in the
with
same
that.
way, now a walking patient comes, I generally don't use 2 antibiotics for ambulatory patients. I would use 1. I mean, whether they have a pneumonia or not is difficult to diagnose in the clinical setup if they are walking.
It is of course true for a pneumonia of mild severity. I agree with that. But my problem is that what is the sensitivity and specificity of the clinical judgment in making a typical or atypical bacterial diagnosis when you are treating a patient with moderate severity pneumonia and above?
Yeah, as I said, if
generally the recommendation is you shouldn't make a clinical diagnosis of atypical pneumonia, and it is considered a microbiological diagnosis.
Yeah, of course. Yes.
Yeah, and just chip in another one. I think you raise a very important point. So when we have the necessary, things at our hand to make a diagnosis with the clinical picture, we have to use these things together. And I think now most of the guidelines now suggest, especially in admitted patients, to give a beta-lactam plus a macrolide together. Probably, and
it is not only to provide an atypical cover, and there is evidence to suggest that combining macrolide therapy with beta-lactam antibiotics improve the prognosis of pneumonia due to atypical bacterial pathogens as well.
So because
of its immunomodulatory effect.
Because that's the immunomodulatory effects, but there might be an underlying cause, as Dr. Veda here correctly said. Sometimes we are mixed. There is a mixed infective pattern in our country, because in our country and throughout the world, we really don't know whether there is a mixed infection as well in these patients. And sometimes these antibiotics are complementary to each other. So that might be the reason that we have a high good outcome when we combine with a macrolide, isn't it? Right. Dr. Veda here now, regarding these atypical infections, there is some, whether the duration of antibiotics, especially when we are dealing with atypical organisms, there's a little bit of a misunderstanding. Some people stop clarithromycin after 5 days when the atypical diagnosis is there. Is there, so for some reason, if you are diagnosing Legionella, which is rather rare in Sri Lanka at the moment, where the duration of antibiotics might be important. So especially when you're dealing with atypical organisms, are there any significant factors that you have to consider there?
Yeah, thank you for raising that question. So then the duration is still a dilemma. So then azithromycin, usually a very good cell penetrating antibiotic. So that's why that 5 days treatment, short course treatment is effective, it says. I hope the senior colleague sitting in front of me will agree too. But however, it depends on the patient that you are dealing with. When we have a very limited diagnostic capacity and you are starting in empirically, and most of the time we continue it without the confirmation. So then when to stop will mainly depend on your hands to decide, okay, whether the patient has improved and we can. And so anyway, macrolides, because of that penetrating effect, that short course therapy is also effective.
When you're talking about azithromycin, how about the clarithromycin?
Clarithromycin also similar, but azithro is more. But our first line recommendation is clarithromycin when compared to azithro.
Yes, that is about the community-acquired pneumonia due to bacterial infection. So when you're talking about atypical infections like mycoplasma infections, do you need to continue up to 14 days of clarithromycin, or do you want to stop it after clinical improvement?
Yeah, so then now the current concept of duration of antibiotics is now changing. Earlier it was that if it is 14 days, it should be 14 days. And now current concept is changing. Then they say if we are giving an initial boost and when the patient is responding, if there's no other immunocompromised and the patient's immunity will work, then you can still consider short course therapies. So the short course therapy is the current trend with this collateral damage. More than the antimicrobial resistance, the main worry is collateral damage. To minimize the collateral damage, if we can provide short course effectively, even for endocarditis.
We have some very good assets in the audience as well, and I see Dr. Namal Jayawardena here, so one of the eminent mycologists here. So, to complement Upul's presentation, Dr. Namal, now you are, I think, working at the Cancer Institute, Maharagama. So, any specific message that you have to give to the audience where you have to think about fungal etiologies presenting as community-acquired pneumonias?
Thank you, Dr. Niranjan. Yeah, as you said, I'm a mycologist at the cancer hospital. It's actually a very difficult dilemma when we are trying to diagnose fungal pneumonias, especially in hematological malignancies. If the patient is neutropenic, if the absolute neutrophil count is less than 500, I would actually give a high index of suspicion for fungal pneumonias. And as I think, as Dr. Upul said, many of the radiological features that you mentioned are seen in our patients. And there are typical features that are there for, especially if the patient is neutropenic, and whether the patient is not neutropenic. So the radiological features may differ. I think your patient was probably not neutropenic, the one that you mentioned about mucormycosis. So obviously the typical mucormycosis pneumonia features were not present. Other than that, I would give, if the patient is not responding to your broad spectrum antibiotics for a few days, say about 72 hours, you would actually want to think about a fungal cause and then go in that direction and do your investigations.
Yeah, one, regarding mucormycosis and fungal infections, I think uncontrolled diabetes, probably, HbA1c about more than 8 or 9 might be a factor, as well as I had a patient with mucormycosis in Badulla where patient had uncontrolled diabetes, as well as the patient later was diagnosed to have a lymphoma coexisting with this opacity. So, Upul, anything to add, especially when in your patient, can you describe the thing? Yeah.
Yes. So one comment on this difficult to treat conditions, as well as the fungal and mucormycosis, aspergillus and other fungal pneumonias to diagnose. So you have to make sure that you collect the sample, proper sample, and send the sample in the correct container. So usually what we see is the blood, whatever the respiratory sample is taken and send it in the penicillin bottle, processed penicillin bottle. And usually if there's any contamination in the transit, you will be getting mucormycosis or aspergillus or candida or that sort of thing. Sometimes with the clinical background, we might think this is due to this organism. But unfortunately, actually this is due to a post specimen collection artifact. So you have to make it very clear that when interpreting the lab test, especially the post specimen collection artifacts.
Yes, Upul?
Yes.
Thank you, Dr. Mahan.
Yes. Actually, I saw these mucormycosis cases when I was in Ampara. So there is a seasonal thing. So usually we see mucormycosis patients in Ampara first half of the year. So usually January to May. And almost all the patients I saw were diabetic patients and early CKD patients. The CKD is a huge problem in Ampara. So early CKD patients means creatinine around 1.8 to 2.2, like that. So these patients, again, the presentation is like the typical community acquired pneumonia. We start treatment, but they do not respond in the usual manner. And slow resolution and persistent symptoms, so therefore we offer the bronchoscopy. And so after seeing many cases of this mucormycosis during bronchoscopy, and we were able to actually then make the visual diagnosis of mucormycosis also. So you saw the bronchoscopic appearance in mucormycosis, and we take the sample and we see under the microscopy our pathologist, and she give the diagnosis, this branching pattern and things. And we used to send to Dr. Primali as well after seen by the pathologist. And once we start the treatment also, we repeatedly do bronchoscopy and see whether it is cleared or not. And the repeated sampling also, it is positive. So therefore, so this is not culture actually, it's a histology. So there is no problem with the contamination. So this is the pattern actually we see. So fortunately, all of our patients survived, and some of our patients offered surgery as well.
Can I just add a little bit to that? I think based on what you saw, it's more like, I'm not sure whether it's a pneumonia or it's more like a fungal ball, what you saw in your patients. And just to,
yes.
I mean, your patient was not immune compromised,
Yes.
and based on your
Yes.
imaging, I just thought maybe it's more like a fungal ball than actually a mucormycosis pneumonia.
Yes.
I would say like since you're talking about mucormycosis in uncontrolled diabetes, you would mostly find the rhinocerebral involving the sinuses more in the diabetics, and in the hematological malignancies, they would go for the full-blown pneumonias as well as the new COVID, post-COVID pneumonias.
Yeah.
So I'm not too sure
Yes.
about you.
Yeah, now,
Yes,
yeah,
yes,
especially
exactly.
especially regarding that patient whom I had in Badulla, who had a right upper zone pneumonia actually, Dr. Namal, and this patient had lymphoma as well, poorly controlled diabetes, and we diagnosed the mucormycosis and then the lymphoma. So we were at a dilemma what to do actually, whether to, if we immunocompromised her further, there is a possibility of invasive mucormycosis. So what actually we did was we seek the help of our thoracic surgeons. So we were able to remove that lung lobe and then start the patient on appropriate treatment, and that she did brilliantly. So the importance is that we have to suspect, and as Upul correctly said, we have to use the diagnostic modalities that are there in our hospitals, especially bronchoscopies. Rather than especially in teaching hospitals and district general hospitals where we have the ability to perform bronchoscopies and invasive diagnostic methods in patients who are having we are having difficulty in controlling pneumonias. I think probably we might have to go early in and we might identify proximal obstructions due to malignancies. We might have identified secondary infections with multiple infective organisms. So sometimes these patients' CRP might improve that in the initial stages.
Yes.
So it might come from about 122 for about 50 and then again rise again. So in that situations, I think as Upul correctly said, isn't it, Upul? We need to use this rather than, CT takes a lot of time to come, but bronchoscopy we can do.
Yes. Yes.
Having said that, just to add, now I work at Sri Jawadanpura where I have better access to imaging CTs. Now, to save lives, we have to focus on getting the CTs done quickly. If you have a good radiologist and you go and sit with him, and a lot of CTs can be done in the government sector which are not done for different reasons, for OT and other issues. So, I use a lot of CT, and mind you, we diagnose a lot of so-called organized pneumonias. Now, because my radiologist is not scared to diagnose it, and I'm not scared to treat them with steroids also. So this entity is there, which would have otherwise gone as resistant pneumonia, who died of Acinetobacter infection, multi-drug resistant, because you keep on giving different things. So radiology you have to focus on.
Yeah. Organizing pneumonia, Upul, would you like to add something about it?
Yes, before that, regarding this mucormycosis, actually in contrast to the rhinoorbital cerebral mucormycosis, what we see in pulmonary mucormycosis is a very indolent cause. Actually, so regarding the case I showed you, it was a fungal ball like in this image, but at the time this patient came to us, it was like a whole right lung opacity. It's, I think, double infection. Patient had pulmonary opacities, pleural effusion plus this lower zone
Maybe
opacity.
secondary
Yes,
cause.
most likely so.
Yes.
With initial antibiotic, he improved, and the persistent opacity is due to fungal ball.
So just one comment to add to Dr. Upul.
Amphotericin, yes. And we refer to surgeons also for surgical removal.
Amphotericin.
I believe it's not an indolent cause. That is because the cause was indolent. That is because you diagnose it very early. So according to the international data, the pulmonary mucormycosis traditionally have a very bad prognosis, because that since now we are vigilant and we are aware about these pulmonary mucormycosis, and we are quite diagnosing. We are doing, as Dr. Naranjan correctly said, we are performing bronchoscopies quite early, and we are diagnosing and starting on treatment appropriately, the course has been changed. If the diagnosis is delayed, so during early days of my career, I have missed several patients with mucormycosis. Many of them died. Okay. So
Actually, I compared this rhinoceros. It is very aggressive compared to this one. Yes.
I have a very simple question. Now we see a lot of atypical pneumonias, and we have drugs like Clarithrol, Acithrol, and levofloxacin. One thing that, do we have data on the antibiotic resistance patterns, like the mycoplasma? We see I don't know. There was an article that there's a resistance among the mycoplasma to Clarithrol. So in that sort of situation, are we? So if a patient comes, which antibiotic you gonna give, levo or Acithrol or Clarithrol? Sometimes when they are on Clarithrol, they change to Acithrol. It is not working. So on what grounds that we make the choice?
just to add to this, it's according to the CDC, as Dr. Dilshan said, it is 90% of the mycoplasma in Asian countries are resistant compared to 10% in the Western countries. So should be the clarithromycin our first choice as for the macrolide cover, for the atypical cover.
Yeah, I'm ashamed to say that we don't have the data to tell you that this much percentage is resistant, because they are not culturable, most of the atypicals. Then if we go for that, then we need to have a sophisticated thing, the genetic detection of resistant genes, that we haven't done yet. So we don't know. So then the starting atypical cover, continuing, duration, switching, all depends on your clever clinical skills, unfortunately.
Would you like, if there's data on the Southeast Asia, would you change to Acithrol or even levo?
Acithrol and Clarithrol, more than the resistance, the potency matters. Acithrol is more potent than Clarithrol. So that's potency matters more than the resistance, because co-resistance, because these are same macrolides. So the resistance they can cross-react, but the potency matters. So Acithrol is better in some aspects, but Clarithrol is better in some aspects.
Dr. Malika?
I want to highlight on the antibiotic misuse also. Because now Dr. Geetal was talking about saving the life of patients. It's very important. Sometimes the patient comes with acute pneumonia, so you whack with very broad spectrum antibiotics. I had a recently patient who had come with an acute exacerbation of asthma and with a probable infection, but they started on meropenem on the admission. But later on you see the X-ray is perfectly normal and the CRPs are very low, but still you're reluctant to stop that drug. So I mean, we have to be mindful, even though a patient looks bad, so patient is bad because the asthma is bad. So you have to be careful of antibiotics.
It's a clinical call, I think, isn't it? Dr. Malika, yes.
Yes, actually one thing I wanted to highlight is already highlighted by Vaidehi regarding potency. The other thing is, Vaidehi, I just want to ask this multi-center study which has been done in China. Now the majority of the infections are due to mycoplasma. What was the tool, the diagnostic tool they had?
Nucleic acid amplification test, madam. NAT.
NAT, no? Yeah. Because we have to think of some sort of diagnosis in Sri Lanka, because atypicals are now rising. So both colleges.
How many years we can say no data?
Yeah,
I think that is the most important thing that I highlighted, Dr. Malika, and I'm really happy that you are here as well. So I think together with the colleges, I think we have to push the ministry to give us point of care etiological diagnostics for not only for pneumonia, for other infections as well. Then I think we can drastically reduce the unnecessary use of antibiotics, and hopefully we can reduce the resistance developing into antibiotics. And if you look at the expenses that we have to incur for high-end antibiotics, for 1 day of meropenem, it might cost, and 1 day of meropenem will cover the whole genome sequencing of one sample, I think.
Free health system. Health system.
Yeah, because we are having a free. No, if you think about the high-end antibiotics, we have to push this at least in each district if we have a reference center that is established for microbiological diagnostics, I think we might be having better data so that we will be able to manage these patients more like in a more focused way rather than in a haphazard way, and we might be able to reduce the resistance, the WAPs and the HAPs most likely. I think hopefully our colleges can get together.
Yeah, actually this is a very good forum that we need to initiate that sort of, because all the other fields, they have lot of sophisticated diagnostics in other laboratory colleagues. Microbiology is still in the very ancient era.
Conservative.
Another thing, when we are using this sophisticated PCR-based nucleic acid amplification test, so we have to be very careful for overdiagnosis. So that is very important sometimes. So when the sophistication increases, so there is a very high chance that we will diagnose false positive ones because of the microbiome. So bioinformatics has to be come into the action as well. Otherwise, it will be overdiagnosis and overtreatment.
So I think it's a beautiful,
The test results should be discussed and correlated with the clinical diagnosis.
Yeah, I think that is why I think the doctors and consultants get trained for about 10 years, isn't it? So we have to make a learned decision regarding our patients rather than just treating the investigation finding as per se. So one last question. I think we are over time, but I think it's a beautiful discussion. This is the type of discussion that we wanted to have actually today. So Malika, I think in your opinion, in the Sri Lankan context, out of these severity indices, what might be the best? I know it's a difficult question, but what might be the best?
The short question answer is when it compared to PSI and curve 65, some studies showed slightly outperforming curve PSI, but clinically it's negligible. So for us, it's curve 65 or CRB 65.
That is the easiest to perform, isn't it? And at least we can base our decisions depending on a very simple, very simple characteristics of the patient. And at the same time, again, we have to look at the patient and the surroundings as well before we go on and jump into conclusions.
Exactly.
Okay. Thank you very much, ladies and gentlemen. Thank you, Geeta, Dr. Vaidehi, Upul, Analika for that excellent presentations. And thank you, audience, for this immersive interactive experience. So hopefully we will break for tea, and we will start at 10:45 a.m. And I think we have the tokens of appreciations to be given, and after that we can break for tea. Thank you.
Thank you, sirs and madam, for that very informative and interactive session. And in appreciation of the knowledge and experiences that were shared today on stage, I would now like to warmly invite Senior Consultant Pulmonologist Dr. Bandhu Gunasena on stage to hand out the tokens of appreciation to the speakers. Dr. Vaidehi Rajivan, Dr. Upul Patirana, and Dr. Nalika Karunaratna. Now I invite our moderator, Dr. Niranjan Disanayaka, to receive his token of appreciation. Thank you, sir.